Welcome to PEM CHATT. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Toni Dobson, and I am located in Chattanooga, Tennessee, and I will be your host. Welcome, PEM Chat listeners, for this episode about dysautonomia. Now, if you're wondering what is dysautonomia, you are not alone in the world. This diagnosis is not something that's taught in school, so many providers have never heard of this term. So that's exactly what we're here to talk about today. Now, you've probably heard of the term POTS. This is not just a TikTok craze. This is a real diagnosis, and it lives under the umbrella of dysautonomia, and we're going to be talking about that more today. So let me paint a quick picture for you ED guys. So you're in the ER and you're seeing a 16-year-old female, and her name is Rachel. She's here for syncope, and she came in via EMS, and her mom is sitting with her at the bedside. This is her fifth ED visit for the same complaint. And she says, every time I come to the ER, they do an EKG, they do blood work, and it's always normal. I know that every single one of you have seen this patient in the emergency department, because I feel like I've seen this patient 100 times in the emergency department, and you may have actually seen this patient more than once. So think about, what are you going to do for her today? Now, hold that thought, because we're going to revisit this a little later in this episode. So today, I'm excited to be joined by two members of the Dysautonomia Project. We have Cheryl Fabor. She is the Director of Education for the Dysautonomia Project, and nurse practitioner June Bryant. Well, thank you guys for coming today.
Yeah. Thanks for having us.
Well, will you guys just take a moment and tell us a little bit about you guys? Cheryl, why don't you start?
Sure. As you said, I'm the Director of Education for the Dysautonomia Project. We're a nonprofit organization based in Clearwater, and our entire mission is to educate about autonomic nervous system disorders. I've been here for 10 years and am very, very passionate about the mission. And excited to
Wonderful.
work with Dr. Bryant, too. She joined us a while back as a medical ambassador.
Yeah, so
Yeah.
I'm June Bryant. I'm a practicing pediatric nurse practitioner. I have been with the Dysautonomia Project since 2019 and recently transitioned into the medical ambassador role. I'm an assistant professor for the University of Tampa, and I also own my own mobile pediatric primary care practice in the area.
All right, wonderful. Thank you both for being here. I met June and Cheryl in Dallas back in March at the AAENP conference. June spoke about dysautonomia, and then they had a table there, so I got to talk to both of you. And you were kind enough to give me this amazing book, which I have since read, and it's quite a great resource. We'll talk about that a little bit later in the podcast. So, again, thank you guys for being here.
You're
So,
welcome.
let's kind of jump right in. Tell us, what is dysautonomia?
Dysautonomia is actually an umbrella term for any disorder of the autonomic nervous system. And the autonomic nervous system is part of the nervous system that controls all of the automatic functions of our body. So things that we don't have to initiate ourselves. So that would include things like your heart rate and your blood pressure and digestion and perspiration, things like that. So dysautonomia is that umbrella term, and it encompasses a lot of different forms of autonomic dysfunction. So, dysautonomia in and of itself isn't a diagnosis, but it's that overarching term for many different types that fall underneath it. And
Mhm.
it's actually um, a lot more common than people realize. There are an estimated 70 million people worldwide that are impacted by some form of dysautonomia. So that's a lot of people. We like to say it's not rare, but it's rarely diagnosed because it's not taught generally in medical school or nursing school. And unless you have a specific fellowship or a specific interest in learning more, you really don't get into the complexities of it to know
Yeah, in the book, they call it the invisible illness, and I thought that was
exactly.
fantastic. Yeah. As I was getting ready for the podcast, I can't help but feel a little nervous, and your heart rate's up and you're sweating, and I was like, "Man, what?" I'm trying to imagine if I had dysautonomia and I felt like that all the time, like how exhausted I would feel
Mhm.
constantly.
Right. That's exactly right. That what often happens with patients who have POTS, you've mentioned that postural orthostatic tachycardia syndrome, which is one of the most common forms, is the body stays in that fight or flight mode, and it's
Mhm.
hard for it to keep that equilibrium and to bring it back down into rest. And so it takes up a lot of energy. Any amount of stress is going to impact a patient who has POTS and put them down for a long time, often, after
Yeah.
that surge. Mm.
Um, in the book, they also talk about how this is a mind-body disorder. I love that description because I feel like a lot of providers wanna say that this is related to a psychiatric complaint. And, we see this with, like, functional abdominal pain in young females in pediatrics.
Mhm.
Parents get frustrated because we don't have a diagnosis or we can't say that there's something necessarily wrong with the patient, but they're having real symptoms, and we talk a lot about how the mind and the body are connected. It's not just one isolated system. We don't take care of one system alone. They go together, and so we have to kind of talk about how those things are connected.
All right, and it's so hard from a curriculum standpoint, especially in school when you're taught some system based. So, you're taught the cardiac system, you're taught the GI system, and hardly is there a time when you're taught about all of the conditions that fall under that can affect multiple systems. So, I think that's where it can get lost too, especially coming from the provider role. So, I think that's why it's important to expand your knowledge and be able to learn about this in this kind of capacity.
Yeah, yeah. And who do you refer to if you don't have a system to refer to, right? You end up at the PCP, but a lot of PCPs don't even know this.
Right.
All right. Well, you talked about this a little bit, but how common is dysautonomia, like POTS in particular? How often can we expect to see this in the emergency department?
The the latest statistic that we've used for a while is that on average, 1 in 100 teenagers is impacted by
Yeah,
POTS. So if you look at that larger, estimated 70 million people throughout the world that have a form of dysautonomia, and then within that, POTS in particular, about 1 in 100 teenagers, that's a lot of people coming through, the hospital doors, emergency department doors, primary care doors, specialty doors, just looking for help. So I think it's a lot more common, especially since long haul COVID. There's more autonomic dysfunction that's being seen as a result of that. What
for
would you
sure, for
say?
sure.
No, I agree. I agree with that.
So, I know we talked a little bit about POTS, but what are the other types of dysautonomia that are out there?
So, some of the more common ones that you might see, especially in the ER, are going to be that neurocardiogenic syncope or vasovagal syncope, orthostatic hypotension. You may see the autonomic neuropathy, which is like usually secondary to conditions like diabetes. There's also some that do occur at birth, like familial dysautonomia, and that's a genetic disorder. So, those are typically the more common ones that you see, but of course, you also see like issues with the baroreceptors, and that can happen post surgery. So there's lots of different types of dysautonomia that fall underneath that umbrella.
I thought it was interesting to know that there's things that we take care of every single day, like these diabetics who have decompensated that have dysautonomic symptoms, and we're not even aware that that's what we're taking of care of. So we're already doing it. We just don't know. So what causes dysautonomia? How do you end up getting it? You kind of mentioned the viral, process.
Mhm.
What are the other ways that people end up with dysautonomia?
Yeah. So, of course, some of the more common viral ones is COVID, but then also Epstein Barr. So we see a lot of Epstein Barr virus that can trigger these symptoms of dysautonomia. I've seen it with surgeries and also injury like concussions. I've had a patient that had a concussion that triggered their postural orthostatic tachycardia syndrome too. Underlying autoimmune conditions. So a lot of these patients are also seeing people like rheumatology because they will also have autoimmune conditions with that, and then genetic predispositions as well. But one of the more common conditions that we see that linked kind of with POTS is Ehlers-Danlos syndrome. So a lot of times we're also doing a secondary POTS screening for anyone that comes in with that disorder as well.
Yeah, we always say autoimmune diseases like to hold the hands of their friends, and it seems like dysautonomia is similar. Like there's typically some sort of underlying condition or some sort of trigger that's happened.
Mhm.
So when you're seeing these patients, you really have to open up your differential and think about the other things that go with it. Mast cell comes up quite a lot in the book, and I know
Yes.
that's another condition that many of us don't know anything about. But mast cell activation syndrome very commonly comes with different dysautonomia types. So,
Yeah.
something to keep in mind when you're seeing these patients. There could be something else at play. So, think about the other things that could be on your differential.
Cyclic
So,
vomiting syndrome too is another one. Cyclic
oh,
vomiting syndrome is one too that we see.
that's interesting. I
Mhm,
haven't heard that at all.
mhm.
I feel like we see that a lot.
Yes.
And we tend to blame it on marijuana use.
Mhm.
How would I maybe differentiate that when it's more dysautonomia linked?
Ask about other symptoms too. See if they have
Okay.
other symptoms that are coming from various body systems, right? So if it's strictly just cyclic vomiting from drug use, they're not gonna necessarily have all of the other symptoms, but that's why history taking is just so important and knowing what questions to ask. And if you focus your history questions on, of course, the general body fatigue and all that stuff, but really hone in on those neuro, cardio, and gastro history symptoms, even just random ones, that will really be a telltale.
Yeah, and that's a perfect lead into my next question, which is what are the typical symptoms for these patients? So,
You're welcome. Um,
what are we looking for?
All right. So I already said, so you're really going to be looking for them in those different body systems, but some of the most common ones are going to be that lightheadedness and dizziness, difficulty standing still. And that's just going to be because of the lack of circulation in the lower limbs. And they're going to constantly, especially in kids, I'm talking about kids and with pot specifically, they really want to be moving around because their circulation is not very good when they're standing up. So a lot of times they're going to look like they need to use the potty, or they're going to be the ones standing in line that aren't standing in line because they're constantly moving around.
Yeah,
Um,
they look anxious.
they look anxious, right? And so, of course, syncope. They'll have tachycardia, fatigue, brain fog. Brain fog is a big one. That's what I have to write for a lot of accommodations for our school age children. Um, Nausea, GI symptoms, constipation, diarrhea, they'll have all of those. Difficulty sweating or producing too much sweat. They don't sweat like their peers. Um, and then, like temperature dysregulation, they feel too hot or too cold because their autonomic nervous system is not able to control their temperature. And then you'll see shakiness and tremors too. Um, what else?
Gosh, I think you've covered
Okay.
all of it. And what
Okay.
makes it so challenging, though, is that every individual is different and can
Mhm.
show different symptoms. So that history taking is so important. And that review of systems from head to toe is so important because everyone could present differently. And so it's very individualized.
Yeah,
And
and that's
the
Right.
severity. So it's not just sorry, I didn't mean to cut you off, but,
it's
like,
okay.
it's not only the symptoms, it's just the severity and trying to hone in on, like, right, how tired are you? Asking them, it's not something that you can measure on a scale, right? How nauseous are you today, right? So
Right.
it's like it makes it very hard to quantify those subjective symptoms.
Do you have, like, a specific checklist that you use for these patients? Is there something that you kinda use as a guide, or you feel like you've developed this because you see them a lot?
Well, I both. The Dysautonomia Project in that book, they do have a clinical assessment tool that really helps hone you in on some of those questions that are really important to ask anyone that you suspect. But the great thing is yes, I've gotten to the point because I do see this and I do have it on my radar that I'm always asking questions like that. The first time that they're like, oh, well, sometimes I feel dizzy or sometimes I feel like this, there it goes. I go right into the question about the specific things. And most of the time, I'll even go ahead and we'll talk about this in a minute, but I'll go ahead and just do orthostatic vitals on them. I mean, what's the harm? They're already there. They're in front of me. They're telling me they have these symptoms. Why not at least give them some hope and say, hey, I think I might have an idea of what this could be, but let's look into it further.
Yeah. The ER, we're always in a hurry. I just feel like we're rushed to see a lot of patients, and so we don't always have a lot of time. What would be the top 5 most common things you hear from patients that would really turn that, like, light bulb on, "I need to look for dysautonomia"?
Good
You want to take
question.
it? You want me to take it?
You go for it.
Okay. So definitely brain fog. Difficulty when sitting up and having symptoms. So they'll say, I ask them if they feel dizzy when they get up in the morning, or passing out, syncope. That's a big one.
Uh-huh.
They say that they've had multiple episodes of syncope. I already have my blood pressure cuff in the hand. Yeah, like
Okay.
I'm going after that.
Difficulty standing still
Right.
is generally one.
Another one is actually I'm just speaking from personal practice. Like what would lead me to jump into it is circulation issues. So blood pooling, like they notice that their legs change color when they're sitting down or even standing up. Um, and I know that there's probably um
Migraines often or stomach issues,
yeah, there's just so many. I don't know how to pick
Yeah.
the top 5, and that's the issue is, like, they need to have at least 5
chest pain.
but oh, chest pain. Yeah, that's a
Mhm.
good one too.
Yeah.
5 different but they all come from different areas of the body, so it's, like,
Yeah.
hard.
And in your talk and in the book, they talk a lot about brain fog. I got to tell you, that's not a symptom I hear in the ER from people a lot. Maybe that's something that primary care hears a little bit more of. And, to me, that's like, it's a little bit of a question mark. Like, what does that mean? Like,
Mhm.
you have trouble focusing? You have trouble completing tasks? What does that mean to the average patient?
Yeah, I think exactly what you said. They
Okay.
have difficulty following through with task, or what I see a lot with my patients is they'll be mid-sentence and be like, "I completely forgot where my train of thought was going," you know? It's almost like having that feeling of walking into a room and forgetting what you walked in there for all the time. So
That happens to me all the time. I've been blaming it on
yeah,
perimenopause.
yeah. Me too.
Okay. Well, I think that's great. And in the book, they talk about the 7 most common symptoms, and it's available for everybody to read. So it's a great resource for people. On average, it says it takes 5 to 7 years for one of these patients to get a diagnosis, which is pretty astounding. Is there a diagnostic criteria that as providers we should be aware of? And I guess that's like a really big question considering that there's so many different types of dysautonomia, but let's just narrow it in on POTS because I feel like that's the one we're going to see the most of in pediatrics. Is there a diagnostic criteria? Is there some box we have to check to say, hey, you have POTS? What does that look like?
Sure. So, because it's an orthostatic condition, that's what we're kind of looking at. So, if we're looking at a simple test that they can do in the office or even in the ER, you can have your techs do it, is the orthostatic vitals test. And we learn about this in school. It's where you have them, lay down for 5 minutes, take their baseline, have them sit up for 5 minutes, take the baseline blood pressure and heart rate, and document any symptoms, and then have them stand up for 5 minutes, and then take their blood pressure, their heart rate, and see if they have any symptoms. So the diagnostic criteria for POTS is if they have a sustained increase in their heart rate of 30 beats per minute, and this is for adults. For adolescents, it's 40 beats per minute, or sustained over 120 on a tilt table test. This also has, in order to classify it as POTS, they also have to have these symptoms for at least 3 months, and they have to they must have symptoms with it. So they must have some of the symptoms of POTS that we talked about, lightheadedness, syncope, something like that, along with this sustained increase in heart rate.
Right. Without
And is their blood pressure typically
Without
affected?
no. So
Okay.
in POTS, it's very specific. There's no decrease in blood pressure.
Yeah, and I think we learn about that in that test, the orthostatic vitals in school, but we're not usually as providers the one doing it. I don't know how the techs in my ER do orthostatic vitals. I have no idea if they let them stand there for 5 minutes. I thought it was really interesting to read that these patients will sometimes have like a normal heart rate when they stand up, but then 2 minutes later, it's in the 120s and it
Mhm.
just stays there and they feel terrible. So, really, assessing how they feel and giving them time in these different positions really can make a difference in what this test looks like. So, maybe a conversation with the techs in your department on how they do these things.
Mhm.
As a side note, the adult ER hates orthostatic vital signs. It's really been shown like to be of very little utility um, for the average patient that you're trying to assess like volume depletion status. Like it's been shown that that's not really a good indicator. But we're talking about doing orthostatics for something very specific. So a totally different use for orthostatics before all the adult ER poo poo the idea of doing orthostatics because I know this is a big conversation among ER providers. Okay, awesome. Well, thank you for talking to us about that. You mentioned the tilt table test. I've heard about that for years. I've never seen one. I would wager most of us have never seen one. What does that look like?
Did you see one? You
I've
watched
watched
one, so
one.
I'm gonna let Cheryl actually take
Yes.
this one because she actually I have not actually I've never had the opportunity. I mean, I've seen videos and
Mhm.
and my patients tell me about it, but
Yeah.
firsthand, I'm gonna have
Sure.
her.
Yeah, it was really quite simple. It was in a cardiologist's office, and imagine a hospital bed, and you lie down on the bed, The patient is strapped onto the table or onto the bed. They're hooked up to the different blood pressure and heart rate monitors and things. And then slowly they're raised up. And while they're being raised, those vital signs are being watched and recorded. They're watching for symptoms, the same kind of things that Dr. Bryant was just talking about with doing orthostatic vitals in the office or in the ER. And they just continue to do that until they're in an upright position. And oftentimes, you've got someone who has fainted at that point. So they're collecting the same data, just in a different environment
Yeah.
than, yeah, using your blood pressure cuff and heart rate monitor.
And it's just that safer place where if they
Mhm.
do pass out, they're not falling onto the floor,
Right, because they're
right?
strapped onto
Yeah.
the
So
table.
it's controlled.
Yeah. I thought it was interesting to know that it's a provocative test. Like, they are trying
Yes.
to make you have these symptoms. And in some clinics, they'll actually give you meds to try and induce some of the symptoms,
Mhm.
which I was completely unaware of. The book shows this really interesting graph about watching the oscillation of cerebral perfusion between, like, your baseline patient that doesn't have POTS and then somebody that does have POTS.
Mhm.
And it shows this distinct difference in their brain perfusion. I thought that was really interesting. Do you guys know much about that difference?
Well, I mean, it's just a matter of the issue being the circulation and not and depending on the cause. Of course, like we talked about all the different causes, but there's different theories that lead to what leads to this decreased amount of perfusion too. And
Mhm.
so ultimately that's the goal is of any treatment that you want is to try and get the brain perfused. And that's the whole issue. So it is really interesting to see the difference in that perfusion in someone that does have something like POTS compared to someone who does not. Because, and it's also good to show your patients that because it validates what they're feeling, instead of saying, well, your tests are fine. I don't know why you're passing out. I don't know why you're having these symptoms. But if you look at that, you're like, well, your brain's not getting blood. So that
Mhm.
is probably why.
Yeah, this is real. Yeah,
Mhm.
you're not making these symptoms up in your head.
Right.
Okay, well, it seems like our treatment options are kind of divided into two sections. We have the non-pharm kind of lifestyle modifications for these patients, and then there's a whole slew of different pharmacological options. Let's talk about what some of those kind of lifestyle non-pharm options are for some of these patients.
Sure. So, of course, this is what we really like to hone in on because I think that a lot of these actually do make a huge difference in a lot of our patients with POTS. So, one of the first things, and before when I was speaking on this years ago, we would go to water intake and we would go to salt intake. And I'll talk about that in a minute. But after listening to some of these providers at these POTS clinics and these dysautonomia clinics, they are really focusing on physical activity,
Mhm.
which it seems like it's counterintuitive for someone who is so fatigued after activity, but that conditioning really does help with the circulation. So even getting them out and doing some of the recumbent biking, swimming, rowing, things like that is so helpful for these patients for that movement. And so that's actually been moved to the top of the list on what these patients should do. And they can do it with help of physical therapy. Occupational therapy focuses on other aspects, but getting some of these therapists involved or early are very important so they don't continue to go down this downward spiral. So then I mentioned hydration status. So water intake is very important. They need to get a minimum of 2 to 3 liters a day usually, and using those like electrolyte solutions or supplement
Mhm.
solutions is also very important for them so that they can help them retain that fluid for longer. Salt, again, that also helps retain that fluid, usually about 8 to 10 grams a day. Of course, that's as long as they don't see a lot of people going, oh my gosh, our hearts are going to be bad. People with hypertension. Well, just think these patients usually don't have hypertension and they don't have
Right.
chronic kidney disease. You have to take that into consideration too. And just make sure that where they're getting their salt intake from is not iodized salt. We don't want them to have 10 grams of iodized salt because then they're going to have iodine overdose. So we don't need that. Just sea salt, adding salt to every meal, things like that. We recommend compression garments. Compression garments will really help with that circulation. And so usually we like the higher the better. So like waist high is really great. And those are things that can also that providers I don't think I would ever see an ER provider order compression stockings. But for those in primary care or recommendations to pass along to your patients, that these can be ordered like moderate strength from medical supply stores, or you can just get them on Amazon. That's good too. Um, Sleep hygiene. This is a very hard topic with adolescents, especially just
Mhm.
because they don't see the need for sleep, but it's very, very important for their body to be able to take that time and rest so they can function fully during the day. And so many adolescents today have such poor sleep habits. I think that it's really important that even as parents, they set the tone and say, no, you need this sleep because of the conditions that you have. And then avoiding triggers. So if you know that standing up for long periods of time, my son actually has POTS. And so, when I know he's going to theme parks, because we're in Florida, so of course we have Disney and all that stuff. He knows that standing for long periods of time is a trigger and that it will trigger some of his episodes. So then we write for accommodation so that way he doesn't have to stand in those long lines, which he loves, of course.
Yeah, I bet
I
he
would
does.
too. But I mean, that's a trigger. I know that also, just talking about different accommodations too, I'm sure I'll talk about it later too, but even, thinking about school-age kids and riding school buses. So sometimes these kids actually need accommodations to ride in an air-conditioned school bus, compared to a hot one because then they'll start having syncope and it will start triggering their POTS.
Yeah, great recommendations. The only other thing I saw in the book was that a lot of these kids are vitamin deficient. So it talks about having your PCP check your B6, B12, D
Mhm.
level, supplementation. I feel like everybody's kind of getting on board with a lot of those things routinely.
Absolutely.
And, in the ER, a lot we want to fix people and we need ideas on how to treat these things. So I think even though I'm not going to maybe write a prescription for a compression garment, it's so helpful to have things that I can suggest for these people. Because, at the end of the day, medicine is half what I know and half how I relate to patients and the relationship that I build with them. And so a lot of times I may not be the person who gets you a diagnosis and fixes everything, but if I can give you just some suggestions or even point you in the right direction, people leave much more satisfied. And I feel like at the end of the day, feel like I've done a better job for patients. So I love having suggestions like that. I think it's great to have a list of things that we can go to. There's a lot of pharmacological stuff here. I thought we could kind of just cover the main ones. I'm not sure for me personally that I'm going to necessarily prescribe for any one of these patients out of the ER setting just because I don't have any experience prescribing these medications and wouldn't know how to dose them. But I think it's good to be aware of these things. And even in my own area, I don't live in a huge town, but here in Chattanooga, I've seen kids on some of these medications for POTS. So I've seen local providers prescribing them. So it's good to know why your patients are taking these medications. So if you could just kind of run us through the top few.
Yeah. So again, it's very individualized. So not every patient is going to be on the same medications, but none of them are FDA approved for POTS or dysautonomia. Remember, we're trying to just look at the underlying symptoms. So a couple of the more common ones that we do see is the fludrocortisone, and we give that to help increase their blood volume. The midodrine, which is a vasoconstrictor, and that helps to maintain that blood pressure when they are upright. You'll also see some on beta blockers, and that helps reduce the heart rate. And it helps with if they're symptomatic with palpitations. I need to think of what else. So you may also see them on some like antidepressants or like SSRIs, but remember that the problem is that a lot of our patients have anxiety or depression as a result of not knowing this condition and the way that they feel about this condition. It's not usually the other way around. It's not anxiety that are causing these symptoms. It's because of how they feel. They feel hopeless and like no one's listening to them. So
Mhm.
you'll see some of the patients on some antidepressants or SSRIs as well. Anything else?
I think, like Dr. Bryant said, it's so individualized. There's not one medication to treat POTS. It's trial and error to see what
Yeah.
works. I know that some patients say that they feel better after having IV solutions if in case of emergency or if they're getting ready to travel, getting ready to go into a time they know is going to be stressful.
Mhm.
But yeah.
And anecdotally, I feel like I give these patients saline when they come in and they do feel better.
They
For
do.
whatever reason, at the end of a liter, they're like, "Oh, I feel better." And I'm like, "Oh,
And
yay,
actually, that's
success."
something that we do recommend. And I know there's a whole bunch of mobile IV clinics like popping up. And I know it sounds silly, especially as a nurse practitioner, say, hey, go get a bag of saline, because especially as a previous ER nurse, you're like, okay, they're all better now. They just got their saline. Well, that's really kind of what they might need. They might be dehydrated, and that's what triggered all these symptoms. So that liter or two of normal saline might have just got them out of their little exacerbation, and that's exactly what they needed. So luckily, the only place that you used to be able, I mean, doctor's offices don't typically do that. Sometimes you'll go to urgent cares, but now they do have these mobile IV clinics. And so
Mhm.
we actually do recommend that if they're feeling like they could use it, they don't have to go to the ER for that. They don't need to go to the ER just to get a bag of saline, right? So I'm actually, in our patients, I'm actually thankful for them.
Yeah. I thought it was really great advice in the book to like when you if you are going to prescribe for these patients to really think about what their comorbid conditions might be and then kind of targeting your therapies toward what those other things might be. So like if you're looking at a kid that has POTS, EDS and MCA, the mast cell activation syndrome, doing like the H1 H2 blockers, as
Right.
opposed to doing something else. So I thought that was really great advice that I found in the book. Okay, let's hit the elephant in the room, and that is the dysautonomia and its tied to mental health conditions. I feel like every provider I've met that knows much about dysautonomia really wants to say this is a mental health condition. Let's talk about that.
That's so heartbreaking, and yet it's so true.
It's
We
true.
hear it so often, and patients regularly say that. I can't tell you how many times patients have said, "I'm just told it's all in my head. I'm not believed. I've given a prescription for Xanax. Go find a good counselor." It happened to our founder, Kelly Freeman. It happens constantly, and it's really unfortunate. I think there's such a lack of knowledge and information about what POTS is, about that dysautonomia umbrella. And that's why we exist to provide education so that patients can get the accurate diagnosis. And just like, was said, it often exists alongside of a form of dysautonomia, but it's because of not being believed. It's
Mhm,
because of feeling hopeless. It's because of being told it's in your head. It's because the healthcare providers and the neighbors and the friends and the school are thinking you're making it up because it's so common to look well on the outside, but to be really sick on the inside. That's that invisible illness
mhm.
thing. So, gosh, you've got your makeup on today and you're looking really great. You're all dressed. You don't look sick to me. So that could just be a huge trigger for that.
Yeah. I can't imagine having all these real symptoms and then just having nobody believe you. That's gotta feel like, an incredibly difficult position to be, particularly as an adolescent where you have no control of your life anyway. You have all
Right.
these adults running your life. You already have this lack of control, and then that's like 100 times worse. And they're like, "Just get up, just function, go to school. I need you."
Exactly. And for adolescents, some of them that are more debilitated may be on hospital homebound. They
Mhm,
may not be able to go to school, and so they feel more isolated. And if they can't go participate in a football game or go to prom, and they're missing out on those social activities. And unless they're real fortunate to have friends that come alongside them and say either I get this or I don't, but I'm here with you, that leads to more depression.
Right, and
yeah, yeah,
a lot of the adolescents, they are high achieving, so they start
Mhm.
off and they're high achieving, they get all A's and they're very athletic, and a lot of times they're both, so, to have this type of disorder come along and completely knock you on your butt where you can't do that, that's just another reason for them to kind of go into this downward spiral,
Right.
and lose hope. I think the other thing that I just wanted to mention on this was the importance of the parental role, because a lot of times for these patients, because they feel like they're speaking, but no one's hearing them. So then the parents get involved. And I actually have had a situation where I've been called by other specialists saying that they think that the parents has, or that's it's a situation of Munchausen's by proxy
mhm,
because the parents know so much and talk for the child, but it's because the child they feel like they're not heard. And so they're having to go through their parents. So their parents keeping all the records of all the specialists and going to see all these specialists and all this. So I've actually had concerns that they were like, well, we think this is Munchausen's case. And I'm like, no, this is not a Munchausen's case.
Yeah. Since you have experience taking care of these patients, do patients ever recover?
Yes. Oh, yes. Yes, they do. They're never cured. I mean, it's always something that they can trigger, but they learn to manage their symptoms. They learn their triggers. They learn who their support system is. They learn who to turn to when things do go south. And actually, my the first patient that the reason why I even got involved in this whole thing was because it took 6 months to get her a diagnosis, and I felt like I was in a downward spiral with her. And so, and she's wonderful. She's doing so great now, and I love to see that, and I just wanna see more success cases like that where they are just so hopeless and don't have a diagnosis or the support that they need, and see more people get that diagnosis early so we can help keep them from going downward.
Right. There's so
Yeah,
many things they can do to improve their quality of life. Even there's such a spectrum on being able to function very easily, being very debilitated and in bed. But no matter where you are, there's things that can be done to get some improvement. And I think being believed and having a support system is just as important
yeah,
as
paramount.
everything else.
Yeah. I met a young man a couple weeks ago. He was in the ER for something totally unrelated, but as I was collecting his history, he said, I had POTS, but it's in remission. And I was like, "Oh, well, I know you're here for this other thing, but we have to talk about this." So, he his mom was like, "I can't believe you know what that is." So,
Oh, good.
so we talked about it. He said that, he did the salt water. He actually did bed rest for whatever his symptoms were, and then after a period of 2 years, his symptoms completely abated. So he has no symptoms now. He's, like, 18 years old, and
Wow.
he's doing really well. So it was really interesting because I had never met anyone that had had those symptoms and then had a full recovery and felt like he was beyond it, so it was kinda cool.
Very cool.
A lot of healthcare providers, like we mentioned, are, get a little prickly when we talk about these topics and aren't always nice to patients. Why do you think it is? Why is that happening? What do you guys think is the basis for that?
With the Dysautonomia Project, we know that it's lack of education. We know
Mhm.
that when I looked at my curriculum book for the pediatric nurse practitioner program, I was like, "Okay," I had Cheryl here, and I'm like, "Okay, let's open up this book and let's see how much there is on the autonomic nervous system." I am not joking you. It was like a paragraph this big, and it just talked about what the autonomic nervous system was. It didn't talk about any of the disorders, nothing. I'm like, "Well, no wonder I didn't learn, I didn't know
Right.
anything about it." But that's all changing. They are becoming more apt to putting things in there, and they're actually starting to ask board questions about autonomic disorders, which is really good. And I know that because I write them. So, so that's really good too. But I think it's lack of education. I think it's in the way that we are educated. Like I told you, it's more system based. So trying to find a way to interweave that within all the systems that could be involved is important. I think that the fact that all of these normal tests that we do. So we do these EKGs and we do all this stuff in the ER, and everything comes back with normal. We're like, oh well, everything's good. Your heart checks out fine, and they're like, well, it doesn't feel fine. So I don't.
Yeah.
I think that misleads clinicians. The multiple systems, it makes it really hard to pinpoint. And taking the time to take that thorough history in the emergency room, you don't have all that time to go through and ask all those questions. And I get it. I mean, eh, that's not where it should be happening anyway. It should be happening in primary care so we can identify it, but you're gonna get the patients those.
Mhm.
I think, another thing is that especially because when we see this start to peak in adolescence is right around, when girls start their menstrual cycles, so I think there's a lot of stigma associated with that, so a lot of times parents or even providers will be like, "Oh, it's just your hormones. It's just your hormones causing all of these symptoms." And then, again, I think that as clinicians and providers, we don't have it in our differential. We don't
Mhm.
connect the dots and put it in our differential. So if it's something we're not aware of, we're not going to think of it. So the bigger audience that we have to say, "Hey, all these weird symptoms, just put this in your differential, just think about it." I think that has moved mountains in where we're at today. So,
Yeah. You're never gonna make a diagnosis you don't know, so
Exactly.
that's right.
all right. Well, let's circle back around to that case that I talked about when we first opened. 16-year-old female, Rachel, she comes to the ER because she syncopizes at school. She comes in via EMS. Her mom's sitting at the bedside. In talking to her, she looks well, right? She looks fine. Her heart rate's 80. She's normotensive. When you ask her to describe how often she has had syncopal episodes, she says, "Oh, I pass out 1 or 2 times a week for the last 9 months." And you're like, "Oh, okay." This is her fifth visit to the ER. School is now worried. She passes out so often. They need some sort of medical clearance before they're even going to let her come back. She has seen neurology, cardiology, all these specialties, and everybody says everything is absolutely fine with her. And, what are you going to do? Where would you say we start with this patient?
I know where I would start.
Well,
You're
tell us what you would do.
okay, well, we're
Yeah.
gonna say I'm gonna read this note, okay? I'm gonna say, "Okay," and I'm gonna tell my tech, "Go in there and grab orthostatic vitals." But first tell me how you're gonna grab those orthostatic vitals because I don't know how
Love it.
you've been trained to do it, so this is how I want it. So I wanna go in there with those numbers in my hands. I've already seen that she's been seen by multiple specialists, so that's one of the another diagnostic criteria is making sure that we try not to make it a diagnosis of exclusion. That's not what we want, but we want to make sure that she doesn't have any of those underlying things. So, seeing that they all said that she's fine and she's still having these syncopal episodes, we're going to do some orthostatic vitals. We're going to give her some fluids, of course. We'll do an EKG for good measure. And we're going to talk a little bit more about her history and say, is it only the syncope that she's having? Are these only the symptoms? So I think asking about all of those other things will help us connect the dots.
Mhm.
Do you
Oh, that's perfect.
Yeah. I actually saw this patient. This happened about a month ago. And I did exactly what you said. And because I'm like preparing for this and reading this book, right? I sit down with her and I start asking better questions. And as it turns out, this family already thinks she has POTS. And they have gone to these specialists and asked those questions, but they haven't really addressed that sort of formally. But they are seeing one of the specialists in our area, one of the very few that will take care of kids with POTS. And so at the end of the day, I was able to say, hey, you need to go back to this provider and you need to discuss with them that you think that this is the diagnosis. But ended up being a really great visit because I could validate her symptoms.
Mm.
We had an intelligent conversation as three human beings, her mom, her, and me. And we were able to make some suggestions. In the ER setting, what other, could we make some suggestions from that like non-pharm list of other things she might try at home?
Oh, absolutely. I mean, always and it's so fun. We are kind of stigmatized as primary care providers because our answer to everything is drink more water. Do you drink enough water? You need to drink more water, right? And I feel like I'd say that to my kids all the time. Did you have enough water today? Well, that's why your head hurts. That's why your toe hurts. That's why everything hurts. You didn't drink enough water. But it's so important. There's a reason why we have been I don't want to say conditions, but that's why we say that because in this case, making sure she's staying hydrated, especially with those electrolyte solutions, I think that's so important. And adding more salt,
Mhm.
seeing what physical activity she's doing. I think you did say that she was. Is she in physical activity? Did you? I don't know.
I didn't even ask her that question, so I think that's a great suggestion.
Right, and
Mhm.
seeing if she is because a lot of them are in athletics, but
Mhm,
it's also sometimes this comes in a period when they are deconditioned, they're not in their season, so it's very important for them to stay conditioned year round. So if let's say
Mhm.
she was an athlete and, it's not the season for that, she still needs to be doing some of these passive exercises or else she is gonna get deconditioned and it's gonna trigger her.
mhm. Is there an electrolyte solution that you typically, like, tell your patients to use? Is there one that works best or has the best concentration?
Oh, that's a great question. There's
There's
so
so many
many.
now.
I
There's
know.
so many
That's
out
why I'm
there.
asking.
Yeah, I mean, I know patients that use liquid IV,
Mhm,
Normalite, drip drop. There's a new one, Buoy. I've seen it showing up on TikTok and Facebook feeds. I don't know much about that one. Vitasium, and a lot of it's just kind of trial and error and what tastes good. But I've heard all of those,
There's the
oh,
banana
banana bag.
bag, the little one. That one doesn't taste very good, but I mean,
Oh, what is that? I've never even heard of that. You buy that?
I think you can yeah, I think you can get it
Yeah.
on most
Okay.
of the
I'm thinking of, like, the old ER banana bag that
No,
they
no,
don't make
no, no,
anymore.
no, 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 not that that's well, I think that's where they got the name from. I mean, it
Uh-huh.
probably is the same stuff, but just the little version.
Yeah.
Okay. And then, if you were gonna refer this patient that we're talking about, like, at the end of this visit, where do I send this patient?
Wow. That's the key question right there. We have a provider finder on our website, and that's a great starting point to find specialists and providers throughout the country. The challenge is there's just not enough. And there may be a cluster of them in one city, but nobody else in another city. So we are
Mhm.
constantly looking to grow that and increase it. So that's a really good place to start, just to go see, is there somebody in this area? Um, and if there is, I would refer them to that person. So
Mhm.
they're going to talk to somebody who's not going to be dismissive and is going to understand what they're experiencing.
Yeah. Have you found that people with insurance can go travel to these places and get it covered by insurance, or do they struggle?
Sometimes they struggle. It's kind of a yes or no. I mean, we've talked to some patients recently who tried to get into some of the major autonomic labs and their insurance was denying them. So it's just so individualized.
Right, and a
And
lot oh, sorry.
oh, that's
I was
okay.
gonna say, and a lot of the providers that do specialize in this are cash-based
Right. Yeah,
Okay. Yeah, makes it hard for everybody.
it does.
because they don't get reimbursed by insurance, so at least
Mhm.
they're there providing care, but gotta get paid somehow.
Yeah, I get it. I get it. Okay. Well, you've talked about this already, but like the Dysautonomia Project, what is this? Tell us about it. Tell us, the resources you guys provide.
Sure. So as I mentioned, we're a nonprofit, a 501(c)(3) nonprofit based in Clearwater, Florida. Our mission is education, so all of our resources are education based. The book that you talked about and that you showed is really the foundation of our education. It was written by Kelly, our founder, who couldn't find answers in our local community and had to go searching for them. And once she and her husband found what was wrong with her, they didn't want anyone else to have to experience just this challenge of so many unanswered questions. So the mantra became education is the number one form of treatment. So the book is sold on Amazon and our website, but I'm happy to send complimentary copies to providers if they want. They can, reach out to me directly or of course go to Amazon or our website. So that's a really good starting point. It's uniquely written. You probably saw with the patient perspective, in layman's terms on the left and the provider on the right. And we're excited to share that Kelly's actively working with many other providers to launch the second edition of the book later this year. It's going to have a lot of expanded chapters, a lot of new research. So, first and foremost, get a book, read a book, talk about it, share it. It's a
Mhm.
good place to start, but go to our website too. There are a lot of resources for patients and caregivers and providers. I mentioned the provider finder, but that's just one. There's a lot of different videos, there's articles and blogs, there's links to support groups, there's a patient assessment tool, which is the only one of its kind. It looks like a little teal cell phone almost right there on the
Mhm.
homepage on the right. And especially if you're undiagnosed and you're wondering if you have this, I would encourage patients to go there and answer the questions. They'll get an email and they can assess, their level of risk for this. Or if they are diagnosed, they can track their symptoms with it. Providers can also go to the clinician program. Our next one is going to be January 30th, 2026. It's a CME accredited 1-day program. It is in person in Clearwater Beach. We are considering a virtual option, so more to come on that. But that's a 1-day intensive training in autonomic medicine led by world leading autonomic specialists. So definitely sign up for that. Yeah, there's lots of ways. There is even a spot on the website you can click if you want to get more involved and see what else you can do to help support us.
Yeah, and some other things that we like so if you since you work in the emergency room and if you have a clinical educator, if you want us to come and do a maybe not come, but maybe do a webinar or something like a
Mhm.
demonstration on how to do orthostatic vitals, there are videos too, but if you want something specific on for us to come, we'd be happy to help any of your listeners, if you would like that, please just reach out to us. We'd be happy to help in any way.
Yep.
Yeah. And it sounds intimidating to read a book. This is the book if you're watching the video version here. But it's really easy to read. Like, I mean, I blew through it.
Yeah.
It's really interesting that, yeah, the left side of the page is written specifically toward patients and then for physicians or any providers on the right side. And so many pearls. I've got little dog ears on like every page of this book.
Feels like my
Of all
book.
the Yeah, of all the things I learned, it was so great. I just can't say enough about reading
Yeah.
the book. So if you don't know anything about it, it's a great place to oh, sorry. It's a great place to start. And you're gonna learn tons and tons of things. All right. Well, anything else you guys want to chat about?
I just want to tell you, you shared that this patient you referenced was your
Hmm.
patient. And I just think, and the young man that you talked about, I think it's really awesome that you listened to them and validated them. And they were probably like, oh my gosh, somebody understands this or somebody's
Hmm.
believes me. Somebody's heard this word before, and so that's awesome. Thank you for doing that because that does make a difference in the life of that patient. We hear so many times, I just wish they would understand um, any provider they go to, but especially in the ER. So thank you for that. Thank you for taking the time to read the book, to educate yourself, to go to the presentation at the conference, to have us on. I mean, it's so encouraging that you're doing this and you're helping us spread awareness. That's what it's all about. So thank you for doing that.
Yes.
Oh, well, of course. Anything I can do to take better care of patients any day. Thank you guys for what you do because I didn't know this existed before the conference. And so I'm sure you noticed, I was like, oh my God, I have to know you guys.
Oh, I'm so glad you did. Well, we're happy to
So,
send more books or, do create customized, personalized, individualized education
Mhm.
in person, virtually, whatever that looks like. The main thing, to end this with, number one, is to have it in your differential. And number two, to know that the Dysautonomia Project is a resource
mhm.
to help give you as much information as you would like as a provider to grow, but also to help your patients.
Yeah, yeah, I love that. And you basically hit my recap here,
Oh,
which is
perfect.
dysautonomia is real, right? Consider this in your differential. Your patient's having real symptoms, so it's very unusual for patients to come to the emergency room and make up symptoms. So often the ER is the first stop. They may have seen other people, or maybe this is the first place. We tend to be the place when people have those initial symptoms that are very acute, and so we're going to be often be the first person. Be a good listener. Like, I can't tell you how many times that saved me when I let them go on about their history or their symptoms. Sometimes you pick up what you need to know when you let them talk. Consider your orthostatic vital signs, like June covered very well, IV fluids, the non-pharm treatments that we talked about, and a referral if you've got someone in your area. So get to know what your local resources are. As soon as I learned about this Dysautonomia Project Physician Finder, I went on there and looked for my area just to see if I've got anybody in my area, which I don't. But I'm very close to Nashville, and they have a
Mm.
lot of resources there. And then, of course, the Dysautonomia Project itself. This is a really cool resource. We are so fortunate to have you guys. Thank you so much.
Thank
Thank
you.
you.
All right. Thanks for being with me today, and you guys have a great afternoon.
Thanks, you too. Bye-bye.
Thank you so much for sitting down with me, Cheryl, and June today to talk about dysautonomia. Certainly something that we are seeing more and more of in the emergency department, so we all need to have some awareness. Now, join me next month when I am going to have a really special guest on, Dr. Dan France. He's actually one of my professors from Vanderbilt University, and he's going to be here to talk to us about mental models. And that really means getting out of your own way of thinking and seeing things from other people's perspective. This is a really valuable skill to have in medicine because we have to understand where our patients come from so that we can have productive joint decision-making conversations. So join us next time when we're going to sit down with Dr. France and talk about mental models. Have a great day. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance.